Hello everybody, welcome to the Dr. Lean Body YouTube channel. Today's topic is about bioidentical hormone therapy. This topic is mainly for the ladies out there listening. I'm going to talk about estrogen, progesterone, and testosterone. The differences between bioidentical hormone therapy and synthetic drug therapy, and the difference between static dosing versus biorhythmic dosing when it comes to hormone therapy. Hormones are very important for both men and women. Men have different ratios of testosterone to estrogen and progesterone in comparison to women. Ratios are much more complex in women than men. Men tend to have more of a daily cycle of testosterone. Women have more of a monthly cycle. So their levels rise and fall throughout a 28-day course. Much more complex and hard to recreate in comparison to what men tend to benefit from a therapy standpoint. Men are just much more simple creatures, it seems. Bioidentical hormone therapy versus synthetic hormone therapy is huge, and I'd advise bioidentical hormone therapy to be the best, in my opinion, the best route to go, because bioidenticals are designed to be exactly like your natural hormones. They are designed to create the same action at the receptor site as your natural estrogen and testosterone and progesterone. When you have a synthetic hormone that's had a methyl group added to it or a hydroxy group added to it, or it's a foreign substance to the body, such as an estrogen metabolite from horse urine, which is basically what Premarin is. You get a different reaction at the receptor site and different result thereof. Synthetic progestins definitely have a different reaction in the body in comparison to natural progesterone. Natural progesterone is very protective and helps offset some of the stimulatory effects of estrogen. And you don't really get this with the synthetic progestin therapy. A large study done in the US years ago called the Women's Health Initiative looked into more synthetic progesterone and estrogen therapies, Premarin, Prempro, and there was a lot of adverse reactions seen in the study, which was actually stopped a bit early. Increased risk of heart attack and stroke and breast cancers were seen, and it seemed to be, after looking at the data later, that the synthetic progestins were the main culprit for most of the side effects and problems seen in that study. But the bioidenticals are studied mainly in other countries. Not a lot of great research studies in the US thus far. There are some out there, the large scale ones that I'm aware of yet, but most of the larger research has been done in Europe. Italy, France has a really big one, and England and some other countries have looked into the safety data and benefits of bioidentical hormone therapy, and definitely seen different results in their findings versus the Women's Health Initiative, which really focuses more on drug therapy than hormone therapy. So there's a big difference there. With bioidenticals, I prefer the cream topical route as the way to go with dosing. You can do bioidentical estrogen and bioidentical testosterone with pellets. A lot of women do this and do a oral micronized bioidentical progesterone capsule with it. This tends to work out pretty well for the first 3-6 months. I haven't had a lot of patients in my practice tell me that this has been a great thing long term for them. There seems to be a bit of a problem with achieving optimal hormone levels without overshooting testosterone. Very commonly see those problems in the pellet patients. You have to be careful with how much you're using there. And if you get too much of hormone, you're going to get subsequent increase in steroid hormone binding globulin, SHBG hormone, which is going to bind up excess hormone, and that's going to bind up other hormones such as your estrogen and progesterone and thyroid and other things. It's going to affect in addition to whatever super therapeutic such as testosterone. The cream route has a shorter half-life. Best dose twice a day to keep levels a bit more stable. It is easily customized. It's something that is easily changed quickly. So I prefer the topical route of administration and dosing. It's easy to try to recreate the biorhythmic physiologic dosing protocol with a cream topical administration versus a pellet therapy where you give a big dose and kind of let it slowly absorb over time, and it's not representative of what you see in young women physiologically as far as what naturally happens in a young healthy female with hormones. What you get is let me draw a little diagram here. Estrogen is low and it rises, peaks, and falls, and then comes up and peaks again and falls, and then you have your next cycle. So that's what it looks like here. Starting levels are low when you start your cycle. They pick up, peak around day 12, come back down, peak again around day 21, come back down until you cycle again. It's not a static kind of flat. It's not a one pill every day same dose that you get with static kind of dosing with say birth control pill. But you get the peaks and valleys throughout. With progesterone, you have a low level when you start, and then you start to see an increase around day 14 or so, 13, 14, whenever you ovulate. Most of the progesterone comes from the corpus luteum of the ovary after you ovulate. You do get some baseline production from the adrenals, but progesterone curvature is low when you start your cycle. It starts increasing around day 13, 14, somewhere in there when you ovulate, and it goes up, peaks around day 21, and comes back down. And as it comes back down, you have your next cycle right in here. So that's what the physiologic curvature of progesterone looks like in a young healthy female. Again, it's not flat and static, like this here. So it's hard to recreate this physiologic pattern of hormones with a pill or a pellet. It's easier to do so with a topical bioidentical cream, in the way that you can adjust your dose up, 1 click, 2 click, 3 click, 4 click up, and then you decrease the dose, and then you increase the dose, and you decrease the dose to try to recreate this natural physiologic kind of rhythm of 28-day cycle of hormones in women. That's what I call biorhythmic dosing or physiologic dosing. And you can definitely do it this way, and then follow up on hormone levels after you've been on that for a few months, and talk with the patient about symptoms and pick up on patterns of symptoms associated with certain parts of the cycle, and make adjustments and customize a regimen for that in particular individual patient, which is definitely beneficial because every woman's different. Everybody's going to need a little different dose. They're going to feel a little bit better. Some women are going to like a day 21 progesterone to estrogen ratio of about 200 to 1. Other women are going to like it about a 300 to 1. Other women like it at 100 to 1. So everybody's a bit different on where they feel the best. The normal range for a luteal phase, which is the second part of the cycle when you have both the progesterone and the estrogen, of about 100 to 500 to 1 ratio. Optimal is typically around a 200 to 1. That's where most women seem to feel the best, but it's customizable in each patient depending upon how they feel. Testosterone with women tends to be a bit flat. They do have a peak around day 14 associated with ovulation. Typically there's a bit of a peak there, and that's about all the peak you get there. So it's a pretty flat with a small peak. It can be dosed separately from the estrogen and the progesterone to try to recreate the true physiologic rhythm of those three hormones in particular. This needs to be checked through a different type of lab study versus your typical venous blood draw. Initially, you can do salivary hormone testing or capillary blood spot hormone testing, or you could do even venous blood sample testing to see where hormones are. But once you start a topical hormone therapy regimen, you get absorption through the skin. It gets into the lymphatics. It gets delivered to the target tissue. From the target tissue in the venous system back to the heart, the blood in the venous system is deficient of hormone, which has already been offloaded to the target tissue. So a venous blood draw is not representative of, not accurately representative of bioavailable amount of hormone at the tissue level when you're doing a topical route of administration. So the best way to do testing is to check your hormone levels via salivary testing, spit testing, or a capillary blood spot testing, which is like a finger prick, just sticking your finger and putting the blood in the little circles, and sending it back through laboratories such as ZRT labs is who I typically use with my patients to see where their levels are. The best time to check is going to be your day 21 to look at the peak progesterone and peak secondary peak of estrogen and the ratio between the two, and that's where you can help make adjustments to get the most benefit. You can also look specifically at a day 12 estrogen peak and try to adjust things to get that to more of a therapeutic level as well if you want to check a couple different times throughout the cycle. But the best time is going to be your day 21, day 22 range. So that's basically the main differences between bioidentical versus a synthetic hormone therapy. Static dosing, such as a 1 pill a day, or doing a pellet administration and then waiting on that to wear off and then doing another pellet, which is not really static per se, but it tends to put you on a roller coaster type dosing regimen, which is not representative of the physiologic peaks and valleys of a 28-day cycle for a young healthy female. So biorhythmic dosing is the most natural way I can think of to do hormone therapy, and trying to recreate youth and the benefits of estrogen and progesterone. Estrogen deficiency symptoms, hot flashes, night sweats, vaginal dryness, pain with intercourse, decreased energy, increased belly fat, and harder time losing weight, easier to gain weight. Those kind of things are seen when hormone levels fall off. Skin quality decline, more fine lines and wrinkles, decreased elasticity of skin. Estrogen is helpful with the collagen in the skin. So those are some of the things that you see in menopause and after you have that transition to not having enough estrogen. Progesterone deficiency usually occurs earlier in life. There's a period in life for women between age 35 to 50, which women tend to have an estrogen dominance issue in comparison. They have enough estrogen, but not enough progesterone, so they tend to be more what we call estrogen dominant. And those patients usually have more problems with anxiety, worry, excessive worry, problem sleeping, decrease in their sex drive, harder time losing weight, easier time gaining weight. These things are definitely associated with that imbalance of hormones, which is a very common issue in women, in particular, age 35 to 50, that kind of into the perimenopausal age range. That's a period of time when you can help with balance of hormones. You can do a luteal phase progesterone supplementation in the second part of the cycle, just to help pick up the progesterone and help with that ratio between the two, to get it to more of a healthy level, which can help with some of those symptoms associated with estrogen dominance. So that's something you can't do until estrogen deficiency becomes more of an issue, and then replacing both the estrogen with the progesterone in a biorhythmic fashion is probably going to be most beneficial. Natural ways to help with progesterone production in younger patients and the older patients too. Not as efficient in a 45-year-old patient versus a 20-year-old, but 20-year-olds definitely have some issues with progesterone deficiency due to lifestyle factors a lot of times. Getting enough exercise, consistent exercise regimen, making sure they're getting enough greens and cruciferous vegetables in their diet. These things definitely help with progesterone production and keeping things in a more optimal range. When progesterone's low in comparison to estrogen, lots of PMS symptoms are associated with that. Tend to have more heavy cycles, more pain with cycles. Those type symptoms can be associated with an abundance of estrogen in relation to progesterone. So not only the postmenopausal or going through menopause patient can benefit from a biorhythmic bioidentical hormone therapy regimen, but those perimenopausal or progesterone deficient / estrogen dominant patients can get some benefit from just doing a luteal phase, progesterone supplementation for balance, to help with their symptomatology as well. Testosterone is not typically something that is a big problem in deficiency, and for women, when it is low, there are some problems associated with the sexual side of things, such as decreased sex drive, decreased ability to climax and orgasm. Having good healthy levels of testosterone does help with those sexual health issues. They also help with body composition a bit. When you have a more healthy level of testosterone, it's a bit easier to add muscle tissue with resistance exercise, and keep your body composition a bit better with decreased body fat, increased muscle. So there are some benefits when it comes to bone health and memory with adequate testosterone as well. So it's another hormone to look at and evaluate in patients that have some symptoms associated with hormone imbalance and deficiencies, and something that can be leveled out and put to a more youthful level if needed. So that's a discussion about bioidentical hormones and biorhythmic dosing. I know there'll probably be lots of questions about that, but I'll try to do some more content in the future, discuss proper site administration of bioidentical creams and some of the things that help with absorption there. Until next time, we'll see you later.